our topic is neonatal jaundice. This will be dealt with in 2 sessions. Neonatal jaundice is the yellowing of the skin and other tissues of the newborn infant. A bilirubin level of more than 5 mg per deciliter manifests clinically as jaundice in neonates, whereas in the adult, 2 mg per deciliter will look ecteric. In newborn, jaundice is detected by blanching the skin with digital pressure so that it reveals the underlying skin and subcutaneous tissue, which will look ecteric. In neonates, the dermal ectras is first noted in the face, and as the bilirubin rises, proceed caudally to the trunk and then to extremities. 60% of term and 80% of preterm infants show jaundice in the first week of life. That means in jaundice is common in neonatal period. The most common is the indirect hyperbilirubinemia, which is neurotoxic. Etiology: bilirubin is formed in the liver from hemoglobin. Glucuronidtransferase is the enzyme that converts the indirect lipid-soluble neurotoxic form of bilirubin to direct water-soluble non-neurotoxic form. Indirect bilirubin increase effective hepatic uptake of bilirubin from blood plasma is happened when there is decreased ligadine, which is Y protein, and increased binding of Y protein by another amines, and defective bilirubin conjugation, which can happen due to decreased enzyme activity or defective bilirubin excretion. Pathological jaundice of the neonate: unconjugated pathological hyperbilirubinemia. Any of the following features characterize pathological jaundice: clinical jaundice appearing in the first 24 hours of life, or increase in the level of total bilirubin, direct bilirubin by more than 5 mg per dl per 24 hours. Total bilirubin more than 19.5. Direct bilirubin more than 2 mg per deciliter. Pathological jaundice of the neonate: increased production, feto-maternal blood group incompatibility, either rhesus or ABO or other blood group incompatibility, hereditary spherocytosis, non-spherocytic hemolytic anemia like G6PD deficiency, thalassemia, vitamin K3 induced hemolysis, pyruvate kinase deficiency. Number 4, sepsis. Number 5, increased intrahepatic circulation like pyloric stenosis or large bowel obstruction. inborn error of metabolism like Crigler-Najjar syndrome, type 1 and type 2. Drugs and hemorrhage like hypothyroidism or breast milk jaundice. Risk of toxic effect: increased retention of bilirubin in the circulation and increased permeability of the blood-brain barrier of beta or cell membrane, e.g. by sepsis, meningitis, asphyxia, acidosis, hypo or hyperthermia, and so. Early feeding decreases and dehydration increases the level of serum bilirubin. Clinical manifestation: jaundice may be evident at birth or may appear at any time in the newborn period. High level may give apathy, poor feeding, and signs of Kernictrus. Signs of the cause. Classification according to the time of appearance of jaundice. Number 1, at birth or in the first 24 hours of life, like hemolytic disease of the newborn, which is resource incompatibility, ABO incompatibility, or other blood group incompatibilities, and other hemolytic anemias. In the second, third day of life is physiological jaundice. In the preterm, it might start at the third or fourth day of life. After the third day and within the first week, it is mostly due to neonatal sepsis. At the end of the first week and up to 10 days, most likely will be due to breast milk jaundice. Prolonged jaundice, that is to say jaundice persisting more than 2 weeks. Classification according to the etiology: either physiological jaundice, pathological jaundice with its various causes, or breast milk jaundice. Approach to jaundice neonate. All newborns should be examined for jaundice at least every 8 to 12 hours for the first day of life. And here, this is important because nowadays the mothers are discharged early after 2 hours of delivery, so it is recommended to keep them for a long time, or to advise the mother to bring her child if she notices that his color becomes yellow. Any infant who appears jaundice in the first 24 hours of life should have bilirubin measured immediately. This can be done with a skin or blood test. Further testing on the infant, especially if the situation and depending on the infant situation and the test results. Here, this is the second part of the lecture, which is titled Hemolytic Disease of the Newborn. It is due to transplacental passage of maternal antibody active against infant red blood cell antigen, leading to its destruction. Hemolytic disease of the newborn could either be due to rhesus incompatibility, ABO incompatibility, or other blood group incompatibility. Now we talk about rhesus incompatibility. 90% are due to D antigen. Of course, there are other antigens, but the most common is D antigen, في capital C antigen and others. Pathogenesis: when a rhesus negative mother gets pregnant with a rhesus positive infant, some fetal blood cell infused in the maternal circulation during pregnancy or at delivery. So antibodies against D antigen will be formed in the mother. During the next pregnancy with similar infant, the antibodies cross the placenta and lead to hemolysis of fetal RBCs. The first infant usually is not affected, but the risk increases with successive pregnancy. For example, the first child will skip developing jaundice. The next will have mild jaundice. The next one will have more severe jaundice, and the succeeding one will be severely affected and might be delivered hydroptic and die. Prenatal diagnosis depends on maternal blood type, which is usually rhesus negative, maternal titer of IgG antibodies. You measure the level of anti-D of antibodies. Amniocentesis, if you take amniotic fluid and by an instrument called spectrophotometry, you will see the amniotic fluid will be yellowish, and there will be three zones, zone A, B, and C. A for those who are more severely affected, B for those moderately affected, and C for those mildly affected. Or you measure the level of bilirubin and hemoglobin by taking sample through per umbilicus blood sample, and you do ultrasound that will show the size of the baby, because those babies are swollen due to severe anemia. Treatment. The aim of treatment is to prevent intra or extrauterine fetal death. Number 2, to avoid neurotoxicity. For this, you use intrauterine treatment by intrauterine blood transfusion, and by induction of delivery. The obstetrician should determine the appropriate date for delivering the mother to avoid the risk of prematurity on one side and the effect of the toxic hyperbilirubinemia on the other side. Treatment of live-born infant. After birth, treatment depends on the severity, and hence you should apply or should do monitoring of serum bilirubin, and then to institute treatment, either phototherapy, which is a common form of treatment of jaundice, or exchange transfusion, and nowadays by giving immunoglobulin, which can lower the serum bilirubin. And phototherapy, as I said, the common form of treatment, or infusion of compatible packed cell if the patient is severely anemic, and exchange transfusion with the blood compatible with both the infant or the mother blood group. The best is O negative blood. And to give sodium bicarbonate if there is acidosis. Rhesus negative body who have had pregnancy with or pregnant with a rhesus positive infant are given rhesus immunoglobulin at 24 or 28 weeks during pregnancy and within 72 hours after delivery to prevent sensitization to the D antigen. And this is sort of prophylactic treatment for preventing the coming baby from developing jaundice. And due to this anti-D, the incidence of rhesus incompatibility has dropped very much. Complication of hemolytic disease of the newborn could include Kernictrus, which is serious syndrome, hepatosplenomegaly due to hemolytic anemia, and inspissated bile syndrome or thickened or dried bile syndrome, and greenish staining of the teeth, and hemolytic anemia later on, and portal vein thrombosis, and sometimes portal hypertension later on. Also bleeding from treatment of the condition by umbilical catheterization also. Then number 2, we should talk about hemolytic disease due to ABO incompatibility. And here the mother will be group O and the child will be group A, B or AB. And this happens after birth, unlike rhesus incompatibility, which can happen before birth or during pregnancy. Its clinical picture is similar. Jaundice will appear few hours after birth, and there is anemia with hepatosplenomegaly, and a similar picture of apathy or poor feeding or so. And the treatment, the investigation are also similar, but here the blood group will be the mother will be O and the child will be A, B or AB. And the comb stats might be mildly positive or negative sometimes. And there is evidence of hemolysis in peripheral blood picture, and there is presence of spherocytes in peripheral blood picture. The treatment also is same, that's to say either phototherapy, skin transfusion, and recently for hemolytic disease of the newborn, either rhesus or APO incompatibility. There is a documented treatment nowadays by giving immunoglobulin, IV immunoglobulin, that is documented to reduce the level of bilirubin. Both condition and other causes of jaundice can lead to what is called Kernictrus. And Kernictrus is a clinical syndrome, neurological syndrome resulting from the deposition of unconjugated bilirubin in the brain cells. It is either due to high level of indirect bilirubin more than 20 milligram per deciliter in term infant, or even in preterm infant the level might be low, even 10, 12, 15 in the preterm might develop jaundice according to their gestational age. This level, but also the level in non-hemolytic healthy baby, the level of serum bilirubin can be allowed to go up to 25 milligram before doing exchange transfusion. Damage to the blood-brain barrier, and this by other factors which we mentioned, like infection, sepsis, meningitis, acidosis, and hyper or hypoxemia. The pathology: there is a staining of different parts of the brain by bilirubin, unconjugated bilirubin, especially the basal ganglia, the substantia nigra and butamine. Side effects of phototherapy is retinal damage due to probably there is missing a slide, but this is the side effects of phototherapy. Retinal damage, so it is recommended to cover the eyes. And hyperthermia, because this machine will give heat also, and the child might develop hyperthermia. So you should check the temperature of the child under phototherapy. And loose stool and dehydration, also due to the effect of heat, and skin rash, and there is what is called bronzed baby syndrome. The skin will turn to color of bronze, and this is the baby under blurry light machine of phototherapy. The machine which contains the white light or the blue light or even the green light, which emitted in a certain wavelength, and the baby underneath it will be naked with eye covered and cover of genitalia, and the baby should be turned from side to side every 2 hours, and the distance from machine should be from 25 to 30 centimeters, and then the child should be given extra fluid, about 30 ml per kg, and this should take 2 to 3 days continuously, and then after the level drop below the phototherapy level, then you can stop it. And this is another slide showing the phototherapy. The eyes are covered. Here the genitalia is covered, but the cover is too much. I think it is sufficient to just put a piece of cloth in the genital area, so as not to cover a lot of skin, which is needed for photoisomerization and change of unconjugated bilirubin to conjugated form, which can be excreted in stool or urine. The second modality of treatment is exchange transfusion, and here we use, as we said, preferably O negative blood, because it doesn't contain any antigens. So the baby will be cannulated by umbilical catheter, and two persons should be attendant to perform the procedure, one for monitoring and tailing, and the other for doing the exchange. And the baby is connected to three-way valve, one pointing to the baby and the other pointing to bathing, and the third one pointing to the blood. And the operator will suck out 10 or 20 aliquots of blood each time, and then he'll throw it out in the basin, and then will suck a similar amount of blood and inject it in the baby. And this procedure is repeated so many times until the total amount which is needed to be exchanged is complete. And for the amount which should be exchanged, you calculate either by giving 2 blood volume, 2 times the baby weight times 85. This will give you a double exchange, or sometimes you can give half exchange by calculating 1 times weight times 85. And the assistant will tell you the amount given each time, in and out, and he will monitor also the baby condition by measuring the pulse, the heart, the pulse, the respiratory rate, the blood pressure, and the temperature, and will watch the child. And if the child gets distressed, the procedure should be stopped until the baby gets stabilized, and then they resume the procedure. And after each exchange, after exchange of 100 ml, one should give 1 ml of sodium bicarbonate and 1 ml of calcium gluconate until the end of the process, which takes usually around 2 to 3 hours. And this exchange transfusion will correct the anemia and correct or reduce the level of unconjugated hyperbilirubinemia, and will wash out excessive antibodies. Usually they say, and you should take a sample before and after transfusion for measurement of the level of serum bilirubin, and after exchange should be about half the initial level. It is indicated when there are signs of Kernictrus, and early sign of Kernictrus, and that's to say decreased or absent Morris reflex and poor feeding, then you should go and do exchange whatever the level of serum bilirubin. High level of indirect bilirubin according to gestational age. And for each gestational age there are charts that determine the level above which you apply phototherapy and the level above which you apply exchange transfusion. And this depends on the gestational age and the weight of the child, and also depends on the age of the child. But this will guide the indication of exchange transfusion. Rapidly increasing level of indirect bilirubin, that's to say if it is more than 5, and especially if the level at the critical level above which exchange is